As you know, multiple lung nodules are something that we frequently encounter in our clinical practice. While we suggest try to figure out the etiology of these nodules, this is really based on a lot of things besides the patient themselves, their demographics, the geographic location where you practice, the clinical context, the evolution, distribution of nodules, all of which is very well described in our literature. So, my aim for today's talk is not to discuss any of these, but to draw attention to the less commonly encountered etiologies of multiple lung nodules while highlighting some of the ancillary CT findings or clinical clues that can guide us towards the diagnosis. What this does is not only facilitates better workup, prevents unnecessary follow up, and also precludes the need for invasive procedures at most times. And we may be actually the first people to suggest the diagnosis. I would be remiss if I do not quickly discuss the anatomy of the secondary pulmonary lobule because most of our interpretation is based on the relationship of these nodules to the secondary pulmonary lobule. So we know that that basic unit seen on CT is bordered by connective tissue septa in which run the lymphatics and the pulmonary veins. The core of the secondary pulmonary lobule, you have the bronchus running with the pulmonary artery, and the lymphatics also surround this bronchovascular bundle going up to the hilum, leading to the what we call the central lymphatic network. The interlobular septa basically drain into the pleura, the biggest lymphatic drainage of the lung, and this is known as the peripheral lymphatic network. Now, on CT, this secondary pulmonary lobule is very well outlined in this patient with interstitial edema, where you can see that smooth interlobular septal thickening secondary to venolymphatic congestion, again, veins and lymphatics in the interlobular septa. And the central dot is a pulmonary artery. The bronchiole is not well visualized because of the walls being too thin or barely perceptible. So when we start assessing multiple lung nodules, one of the first things we need to do is assess or look along the pleura for perilymphatic distribution. So not only are we looking along the pleura as outlined by these green dots in the diagrammatic representation, we also look along the fissures and the bronchovascular bundles because that is where our lymphatics run, as shown in this case with sarcoidosis, where you can see these perilymphatic nodules not only along the pleura, but also along the fissure and a few nodules along the bronchovascular bundle in this patient with sarcoidosis. Another case of sarcoidosis where you actually have dominant pattern of peribronchovascular um, distribution of lung nodules. You can see those nodules along the bronchovascular bundle, but also notice the small nodules along the fissure and along the pleura, increasing our confidence of calling perilymphatic distribution of nodules. At the same time, I would also like to emphasize the value of the sagittal reconstructed images, which show us these really small nodules along the fissures very well, and that also along the pleura, and that helps increase our confidence level of calling these as perilymphatic nodules. Moving on, the second set of nodules that we would see that touch the pleura are random lung nodules, which actually do not maintain any kind of consistent relationship with our secondary pulmonary lobule. We see multiple lung nodules distributed throughout the lung, and the two most common causes being metastatic disease and miliary infection. When compared to miliary infection, which you see the homogeneous, similar size lung nodules throughout the lung parenchyma, random lung nodules in metastatic disease can often vary in size and may be associated with other findings of malignancy, such as thickened interlobular septa or bronchial wall thickening, suggesting lymphangitic carcinomatosis, as was in this case with thyroid cancer. Lastly, the third group of lung nodules are the centrilobular lung nodules, which we know can present as centrilobular nodules with tree and bud distribution or simply centrilobular nodules. When we look at the nodules, centrilobular nodules, we're looking for that distinct separation from the pleura, relatively ill-defined nodules, often of ground glass density, and we also use our axial MIP images to highlight that tree branch with the branching opacities that are these centrilobular nodules with tree and bud distribution, as seen in this patient with Mycoplasma pneumonia. Now, centrilobular nodules can exist without the tree and bud distribution, as seen in this patient with non-fibrotic HP, where you can see these ground glass nodules in the center of what would be the secondary pulmonary lobule, almost a photographic negative of our patient with interstitial edema, where the interlobular septal was defined in white. And here it is basically seen as the black line. Again, note the separation from the pleura and the fissure over here. These centrilobular nodules can further be subdivided into peribronchial, angiocentric nodules, nodules that are pure ground glass density, nodules that occur in fluffy cotton bud-like distribution, and then relatively increased density nodules. Now, once we've decided the distribution of the nodules, we form our differential diagnosis. So let's go ahead and look at some cases. Again, I'm not going to discuss the usual. Our first case is a 72-year-old male who worked in construction presenting with shortness of breath. So after we ignore the emphysema, we notice that there are multiple nodules along the pleura as shown by these yellow arrows. The axial MIP images help bring these out or enhance the appearance of the same and also show us the nodules along the fissure. Now, this finding of perilymphatic nodules, predominantly in a peripheral network of lymphatics, in combination with what we saw as eggshell calcification of the mediastinal lymph nodes, should make you think about silicosis, which we know is an occupational lung disease secondary to inhalation of silica and can present in various forms. We just saw the example of the simple form of silicosis, which is upper lobe predominant, subpleural and perilymphatic distribution of nodules, or the complicated forms, which appears as coalescing nodules forming perihilar masses with a progressive fibrosis and also referred to as progressive massive fibrosis. Here, I would like to emphasize the presence of eggshell calcification really in patients with upper lobe predominant perilymphatic nodules should make you think about silicosis as the cause of these nodules. Moving on to our next case, was a 57-year-old patient with metastatic oral squamous cell carcinoma of the oral cavity being treated with pembrolizumab. The patient presented with shortness of breath soon after starting therapy, and the CT scan was obtained for assessing the complications of the medication or progression of disease. What we see over here are these perilymphatic here, predominantly peribronchovascular distribution of tiny lung nodules. As you can see, upper lobe predominant nodules, some of which were also reaching the pleura. This combined with the history of the therapy that was given to the patient should make you think about sarcoid-like reaction, which can occur in patients being treated with immune checkpoint inhibitors such as pembro, but also other therapies like HART therapy, interferon therapy, and TNF-alpha antagonists. Sarcoid-like reaction is basically a systemic granulomatous response that affects the lungs and also at times will affect the lymph nodes that are draining that neoplasm or at a site of chronic inflammation. The key here to help kind of guide the diagnosis is the temporal association of the start of treatment and the presentation of symptoms or an abnormal CT scan, because neither on imaging or on pathology can we really differentiate this from true sarcoidosis. The treatment consists of removal of the drug, or which will result in a resolution, or at least will not result in progression of the process. So, upper lobe predominant perilymphatic nodules in someone with start of these offending agents can suggest the diagnosis. Let's look at the next case of perilymphatic nodules in the 76-year-old female with an abnormal chest radiograph incidentally obtained for after motor vehicle accident. On CT scan, one can see these few peribronchovascular nodules, some of which demonstrate central bronchial dilatation. There is a ground glass halo around most of these lung nodules. These persisted on multiple scans, and patient basically remained asymptomatic in spite of this. And so to suggest the diagnosis of mucosa associated, or henceforth being referred to as malt lymphoma, you have to think about these multiple nodules, which can either be cavitary or non-cavitary, but the distinctive feature which I find helpful is the presence of this bronchial dilatation within the nodules. Now, overall, primary lymphoma of the lung is extremely rare, but the most common form of primary lymphoma of the lung is malt lymphoma, a B-cell lymphoma, usually in patients who are 60 years or older. Another key feature I find helpful is the patients can be asymptomatic, and this disease may slowly progress. Remember the association with Sjogren's disease and autoimmune disorders, which also helps in further narrowing the differential. Now, I'm showing you a case of malt lymphoma with nodules, but they can also present with masses, which may or may not cavitate. As we talked about, the bronchial dilatation, also known as the air bronchogram sign, is really related to the fact that there is infiltration of the bronchial wall by the lymphoma, but not leading to destruction of the bronchial wall. And on larger nodules and masses, you may also see a vessel traversing known as the CT angiogram sign, and that vessel does not appear distorted, narrowed, or occluded. They show low level of FDG avidity, and a biopsy may be necessary for more accurate diagnosis, but this is something that we can suggest if we see the air bronchogram sign or the CT angiogram sign. And and the case is usually managed with chemotherapy. The next case of perilymphatic nodules was this 43-year-old woman with common variable immunodeficiency, or CVID as we call it. You can see multiple distinct ground glass nodules, some of which demonstrate a bronchial halo, some of which are more consolidative and confluent, while some of them are more distinct and are also located along the peribronchovascular bundles. These were lower lobe predominant and persisted on multiple scans, with the patient not showing any symptoms of infection. On CT, one also looks for splenomegaly, which is always associated with these multiple lung nodules. So together, these two findings should suggest the presence of glioid or granulomatous and lymphocytic interstitial lung disease, which is always associated with CVID. And that is because of the infiltration of lymphocytes and granulomas in the lungs, as suggested by the name, which results from systemic immune dysregulation. The HRCT findings are lower lobe predominant peribronchovascular nodules and ground glass opacities associated with splenomegaly and lymphadenopathy. In fact, when you see this with splenomegaly, and if the patient does not carry the diagnosis yet of CVID, you can definitely suggest it. The diagnosis can be confirmed on biopsy, but it may not always be necessary if the patient has known CVID, since it really does not change the management of the disease, and it is rarely progressive. Moving on to centrilobular nodules, while HP and respiratory bronchiolitis remain some of the most common differentials for that, we look at cases separate from those two conditions. So this was a 35-year-old who presented with persistent cough. CT chest shows beautiful ground glass density, centrilobular nodules. Again, if you look at this carefully, it looks like a photographic negative of the interlobular septal thickening. These nodules, some of them did demonstrate punctate areas of calcification, and with the presence of additional findings of vascular calcifications in the chest wall, atherosclerotic disease in someone who's 35 years old, and with the presence of a osteodystrophy, renal osteodystrophy, which I've not shown you here, you can suggest the diagnosis of metastatic pulmonary calcifications. Although the name suggests metastatic disease, it's not really metastatic disease, and calcifications don't necessarily have to be present on CT scan to provide this diagnosis. It is a metabolic lung disorder related to chronic elevation of calcium phosphorus product, which leads to deposition of calcium in the alveolar walls, as shown on this H&E stain. It's usually asymptomatic but can present with nonspecific respiratory symptoms and can be present diffusely or can be patchy. That can also present as non-resolving ground glass centrilobular nodules, diffusely calcified nodules, and I have seen cases of high attenuation consolidation related to the more confluent opacities produced by this condition. One has to remember that even if the nodules are not calcified, you can easily obtain the diagnosis using a bone scan, which will show increased uptake in the lungs, even if the nodules are not calcified. The management consists of treating the hypoparathyroidism, which may or may not reverse the condition. So in the presence of centrilobular calcified and non-calcified ground glass nodules in end-stage renal disease, one must think about pulmonary metastatic calcifications. The next case is a 46-year-old with connective tissue disease showing these beautiful ground glass, evenly distributed centrilobular nodules in both lungs. The patient was presented with cough and shortness of breath. Obviously, infection is one of our differentials, but the unique appearance and the persistence of these nodules on subsequent scans led to more detailed evaluation where my arrows here point out to these areas of associated peribronchial ground glass opacity. So there is a central lucency in several of these lung nodules. That appearance, the persistence of these changes, and the fact the patient has connective tissue disease should make you think about a condition that is follicular bronchitis, consisting of which is basically benign lymphoid hyperplasia of the bronchus associated lymphoid tissue. Oftentimes, you will see these distinct centrilobular peribronchial ground glass nodules, but you can also see what is described as centrilobular tree and bud appearance that can coexist with these nodules. And what is characteristic about these appearance are these little fluffy densities, ground glass and densities along those tree and branch appearance, which is described as a cotton in bud nodule, and a picture to show you what cotton in bud nodules appear in real life. And you can see that equivalent on CT scan. Both these can exist independently, the CT appearance, or can appear together in follicular bronchitis. We also need to remember that this is frequently seen in patients with rheumatoid arthritis and Sjogren's disease, besides immunodeficiencies and HIV. And here is a magnified image showing you the peribronchial distribution of the nodule. The diagnosis can be confirmed at biopsy. However, the CT appearance is pretty characteristic in the appropriate clinical context. At histology, one may see hyperplastic lymphoid follicles with reactive germinal centers in the walls of the bronchiole. And the treatment really consists of treating the underlying disease rather than this entity itself. So centrilobular ground glass nodules in a peribronchial distribution with or without cotton bud appearance, especially if persistent, should make you think about follicular bronchitis in patients with connective tissue disease.